Well, hello. Welcome to the webinar, Accessing Behavioral Health Services, Can Peer Support Help? My name is Henry Iries, and I'm delighted to be able to welcome everyone who has joined us this afternoon. I'm delighted to be able to introduce Dr. Vatisha McClare, who is a social science research analyst at the Center for Medicare and Medicaid Innovation, also known as CMMI. And Dr. McClare is going to introduce our speakers today and also introduce the topic. So, Dr. McClare.
Thank you, Henry, for that introduction. I'm Vatisha McClare. I am the lead for the Healthcare Innovation Awards, and we'll talk a little bit about that. I'm happy to join you guys today to discuss accessing behavioral health services and how can peer support help. So before we get started, I wanted to give us a working definition of peer support. But before I say this, I want to say that there is no one definition of peer support. But we want to give the audience at least two definitions to get us started as we're having this conversation. So first, by NAMI, getting help from someone who has been there. And then also by Via Hope Texas, which defines a peer support specialist as an individual in recovery who has been trained to effectively use his or her recovery to help other individuals with their recovery. So those are just two definitions, but like I said, there are many, many more, but that's a place to get us started. Peer support services in general has a long history of federal support. So starting even in 2003 with President George W. Bush and his New Freedom Commission, which recommended involving consumers in fully orienting the mental health system towards recovery. Then later in 2007, CMS, so Centers for Medicare and Medicaid Services, designated that peer support services was a billable service for adult beneficiaries, particularly those in Medicare, but also in Medicaid. And then later in 2014, the Protecting Access to Medicare Act mandated that certified community behavioral health clinics provide peer support services. And even most recently, as 2 years ago in 2015, Health and Human Services, particularly the Assistant Secretary for Planning and Evaluation, ASPE, conducted an evidence review of the effectiveness of peer support services. So, what that review found was that in general, there is some evidence of effectiveness of peer support services. Peer support services have been shown to decrease hospitalizations, 30-day readmissions, involuntary admissions, producing greater satisfaction with personal circumstances, promotion of feelings of hope, self-esteem, social inclusion, engagement, and so forth. Largely, the paper found that peer support programs were not only feasible, but they could be implemented without detrimental effects. But the outcomes were difficult to discriminate from traditional services. So in other areas, we've also found the similar results, but for peer support services specifically, we know that not only is it possible and promising, we need more research in this area. Most of the studies that were looked at for this paper lacked either comparison groups or longitudinal follow-up. So we wanted to take our resources in Centers for Medicare and Medicaid Services and add to the body of research in this area. So that brings us to our Healthcare Innovation Award. In 2012, CMMI, Center for Medicare and Medicaid Innovation, awarded 108 awards in general areas to improve health and healthcare services and lower costs for high-need Medicare, Medicaid, and CHIP beneficiaries. These programs usually included some workforce components to them, and a lot concluded either lay healthcare workers and or peers. There were 8 groupings for evaluation purposes. One of those groupings that we'll focus on today was in the areas of behavioral health. There were 10 of these awards, and they varied in different models of integrated care, crisis services, use of technology, early intervention, and also substance abuse services. The award amounts for these awards varied from $1 million to up to about $17 million. The federal evaluation is in the process of concluding. It was conducted by Mathematica Policy Research, and we'll hear more about the evaluation later from one of our speakers, Crystal. But each award that we gave who we awarded a Healthcare Innovation Award to was also evaluated by an independent federal evaluator. So our behavioral health awards were evaluated by Mathematica, but there were others that were evaluated in other circumstances. For more information about the awards in general and the HCIA specific HCIA awards, you can go to innovation.cms.gov/innovations/healthcare innovation awards, and it'll tell you more about our healthcare innovation project. Also listed are the evaluation reports for each of the 3 years that the program was in existence. So, before I introduce our speakers, I want to have a poll to see who's joined us today. You should see a polling box that will appear on your screen, and that polling box will tell us, we would like to know whether you provide peer support services, work as a peer as a colleague, work as a peer as a colleague, administer or oversee a peer program, evaluate effects of a peer support services, receive peer support services, or are not currently involved in peer services. So I'll present those results in a few moments, so I'll give you time to fill out our poll. And I'll introduce today's speakers. So today we have 2 of our awardees from the Healthcare Innovation Awards that incorporate peer support, and they'll tell us a little more about how they do that. And then we'll have a representative from Mathematica tell us about our empirical federal evaluation results for those awardees. And lastly, we'll have a discussant. So first up, we have Jamie Nichols, who is the Chief Program Officer for the Bureau of Mental Health, the New York City Department of Health and Mental Hygiene. So Jamie will be describing Parachute NYC, which is one of our HCIA-funded programs. And then secondly, we have Kimberly Goodwin, who is a clinical practitioner team leader at the Center for Healthcare Services in San Antonio, Texas. And Kimberly will be discussing another awardee, CHCS, and their experiences with hiring and integrating a peer workforce in their HCIA-funded program. And third, we have Crystal Blyler, who is a senior researcher at Mathematica Policy Research. And Crystal will be describing the evaluation findings for these 2 programs, including the results of our impact analysis. And lastly, we have our discussant, Daniel O'Brien Mazza, who is the National Director of Peer Support Services for the Veterans Administration. So Daniel will be commenting on the implications of these programs in the evaluation results. So just a little bit of housekeeping to keep in mind. We invite everyone to submit questions electronically via the Q&A widget. At the conclusion of Dan's presentation, we'll post those questions in a slide format and provide answers from our speakers. We will be recording today's presentation, and it'll be available on Mathematica's website in approximately a week. So let's get to our polling results, and we can see who we have in the audience. So majority of our audience members are not currently involved in peer support services, about 39.3%. And then next highest category are people who work with a peer or consumer specialist as colleagues. That's not true. Our second is actually people who fund, administer, or oversee peer support service programs, and then people who work with peer support or consumer specialists as colleagues. and then following up with people who provide peer support services, and about 17% evaluate the effects of peer support services. So we have a quite diverse audience. Everyone can see the polling results. And now I am pleased to turn the virtual microphone over to Jamie Nichols for our first presentation.
Hi, everyone. Thank you so much for that introduction. I'm so pleased to be here today speaking with all of you about peer participation in Parachute NYC Crisis Respite Centers. Oh, sorry, I'm just getting used to the... Try that again. There we go. Parachute NYC, of course, didn't invent peer support. The work you'll hear about today grew out of a long history. Of course, the legacy of deinstitutionalization is something all of us work with every day. The concept of psychosocial rehabilitation, the nationwide recovery movement, civil rights, human rights, the concept of mental health peers, these were all ideas that have been making headway, germinating over decades. And here at the New York City Department of Health and Mental Hygiene, we had my predecessors had the foresight to develop an Office of Consumer Affairs, specifically charged with representing the consumer point of view and advancing the recovery agenda here in the behavioral health care system in New York City. This office really deserves the credit for demanding that we do better by people experiencing behavioral health crises in New York City. And so when the Healthcare Innovation Awards came out, I think the funding opportunity came available toward the end of 2011, we knew that we had a great idea, a great way of delivering better care, achieving better health outcomes, and lowering costs by developing a citywide system of care to provide a soft landing for people in crisis. So that's where the parachute comes from. It's about a soft landing for people in crisis. So this system included 4 treatment teams providing in-home support to people experiencing crisis. Those teams engage people and their families. It included 4 crisis respite centers for times when a person needed more support than they could get at home, and a peer warm line for telephonic support. So today I'm really let me just let you know that there were 85 new jobs created as a result of this system of care, 64 of which were for designated peer roles. So it was largely a peer-driven crisis service system. Today I'm really going to focus on the one piece of our system, and that's the crisis respite centers. You can see a picture, 2 pictures of the respite center in Manhattan, operated by an agency called Community Access. It's a home-like environment. During the grant period, people could stay there for up to 14 days, and we used a model, an approach called intentional peer support. And of course, we provided that peer support, wellness education, and skill-building activities. There was also on-site medical screening, referrals, education, psychoeducation, connection to education supports. The staffing pattern included 12 peer specialists and 2 master's level mental health professionals. So there was 24/7 coverage. The idea, it was not a structured environment. In fact, it was just the opposite. Largely in my career, I heard people talk about the need for a person in crisis needing structure, and we found just the opposite. We found a home-like setting with really informal relationships and activities was really helpful to people in crisis. Also, the doors were not locked. People came and went as they pleased. They were able to stay connected to things in their life like work, childcare, education, parks that they like to hang out in, walks that they like to take, all the things that help them get through hard times they were able to continue to access while in the respite, as opposed to being cut off from those things during an inpatient stay.
Hey, Jamie?
Yep.
Are you muted?
No, can you hear me?
I can hear you.
Can you hear me?
Can you check that your phone isn't muted?
I'm not muted. Hello?
Okay.
Can you hear me?
This is Dan. Jamie's responding, and she can hear, and I can hear her.
Okay. Sorry, go ahead and continue. There must just be an issue with some folks who can't hear. I apologize. Go ahead and continue.
Okay, I'll speak up a little bit too. So the principles of intentional peer support are worldview, connection, hope-based conversations, and mutuality. It's a trauma-informed approach to care. It's not a script or a protocol, but really a way of expressing and sharing our common humanity. So what's so innovative about what I just told you? 6 years later from when we conceived this idea, it's starting to seem more normal. But 6 years ago, it was really quite revolutionary here in New York City to offer people in psychiatric crisis an alternative to emergency rooms and hospitalizations. We encourage staff to recognize the dignity of risk and the right to fail, rather than manage and mitigate risk, which was more common in crisis services. The respite has no security staff. As I mentioned, people came and went. There were no guards, no locked doors, no taking off your belt. People really were encouraged to feel like adults, human beings, responsible for their own selves, but able to access additional support. Peer staff vastly outnumbered non-peers. Peers were not an afterthought. There was no tokenism there. They were and remain the driving force of this service. As I mentioned earlier, we really strive to help people stay connected to their life throughout the crisis rather than taking them out of their life. We think that's really important. About 25% of the people who came into the respites were either working in school or engaging in full-time child care. And they were able to keep doing that to meet their responsibilities to the world and to do things that made them feel important, valued to their community and their loved ones. Most support was provided informally. Again, this was not a structured setting. There were not necessarily scheduled groups unless the group of people who were staying at the respite at a given time asked for that sort of a thing. One of the most powerful interventions, if you can call it that, offered at the respite is the shared meal. Mostly dinner time, the group of people come together to figure out what they want to eat, when they want to eat, and how they want to prepare that. And this really human process of connecting and breaking bread together was an amazing tool for engaging people and supporting them through really difficult experiences in their life. It was this engagement, this relationship, trust, and respect that was really the primary intervention offered by the Parachute Crisis Respite Centers.
Hey, Jamie.
Yes.
Sorry to interrupt you again. I just need to do something quickly. Hang on.
Okay.
Just take a quick second.
Sure.
The host has joined the conference.
Okay, we had a little bit of a technical difficulty, and we sincerely apologize. We are recording this event so that folks who missed portions of Jamie's presentation can hear it at a later date. We should be back on now. And Jamie, I apologize for having to cut you off in the middle of your presentation, but you should go ahead and continue when you're ready.
Okay, sounds good. So obviously there were challenges with rolling out such an ambitious project. Of course, it was innovative. There was no manual to follow. We had to write the rules as we went along. And with such a large workforce expansion, as I mentioned, the 85 new jobs, 64 of them being peer jobs, there were some hiccups. We had, probably about a dozen partner agencies. I worked for a local health department. We worked with contracted community-based organizations to deliver these services, and some of them had more experience than others hiring and retaining peer staff. It's new. It's hard. It's a new discipline within the workforce, and it took some learning. But toward the end, I think we all sort of made changes and understood a much more effective way to hire and retain this workforce. Defining new roles of team members' roles for this new discipline, the peer discipline, was challenging. Who does what? Who's in charge? The issue of power sharing was something that we constantly had to work with, talk about, process. Power sharing between peers and clinicians on the service provider side, and then between the providers, the peer and clinician providers, and the consumers themselves. In a crisis situation, as usual, in a hospital setting or emergency room, there's a very clear hierarchy. We were challenging that, and in our hospital alternative, these respites. And it was very hard for the people who were losing power to give that up and to recognize that that's what they were feeling and experiencing. It was also more difficult than we expected to develop a referral pipeline that trusted largely peer-delivered service in a crisis. We thought in the beginning it would be easy. Look, hospitals, we can, hospitals, managed care plans, providers, we can give you a cheaper alternative to the hospital that people will like. They will go there voluntarily. We thought that was such an easy sell. But it was very difficult to convince the community of providers who interact with people in behavioral health crises that this was a safe alternative to a hospital. Over time, we did that. But it was a slow process. We did not use coercive practices. As I mentioned, there's no security. There were no police, no ambulances, no injections, no mental hygiene courts. All of the things that exist in mental health care to override a person's own will were not needed. We did it without that. And it worked. It was safe. Nothing bad happened. On a more structural level, we found that there was really no established community of practice for the peer workforce, and a place for, is it a professional organization, a union, or online supports, whatever it was, where this workforce could come together and really assert their place in the provider community. Additionally, we struggled, I think ultimately did well, but struggled to develop local training resources. We were, thanks to the grant, had a lot of funding available to bring people in from all over the world to do the training. But to sustain this after the grant, we really needed local people to become expert trainers themselves. The grant period ended 2015. we had a number of, all of the services that we developed during the grant live on, some exactly as they were during the grant, some have evolved a little bit. Parachute peer respite model is now reimbursable by Medicaid in New York State for certain Medicaid beneficiaries. A number of new services became reimbursable in New York State, a number of recovery and rehab-oriented services in the beginning of 2016, about a dozen. Crisis respite being one of them, and that's now the leader statewide in paid claims for these home and community-based services. So we're very proud that we are pioneers and really succeeding, and grateful to the startup funding that we got through this award. The peer warm line model that I mentioned earlier has been incorporated into a massive call center that New York City procured last year. And just since October, peer specialists with NYC Well have provided 19,000 calls, text, and chats using peer support alone. So that's a massive scaling up of peer support using the intentional peer support model in New York City. Mainstream services and institutions are progressively incorporating peers into their traditional services. Everybody understands the value of the peer perspective and the effectiveness of peer engagement skills. Here at the New York City Department of Health and Mental Hygiene, we are incorporating peer specialist roles, multiple peer specialist roles, not single token roles, but multiple roles into nearly every new service that we develop. And the trainers that I mentioned earlier, the experts that we developed through the Parachute NYC grant are now really leaders in the peer services field here in New York City. So with that, I will pass the presentation over to Kimberly, and I look forward to hearing the other presenters and responding to your questions later in the webinar.
Thank you so much, Jamie. It's so inspiring to hear all the amazing things that Parachute is accomplishing. Our presentation from the Center for Healthcare Services is going to look a little bit differently. We're going to provide some brief context and overview of the project, but really focus in on some practical program development ideas on hiring and integrating a peer workforce. So why did we choose this specific project to include peers? One of the reasons was we had co-located medical and mental health care clinics already existing on the same campus at Haven for Hope, which is a transitional shelter for people experiencing homelessness. But for some reason, people were still not accessing medical care. It was a highly stigmatized population that we were working with, people who had been experiencing chronic homelessness as well as working in their mental health recovery. So there was a really strong distrust of service providers or other people in general. There was also a high number of EMS calls to the area because people were not accessing medical care on a regular basis, and so were accessing more emergency medical care services. So peers were definitely viewed as a potential for helping with engagement, helping to build trust. So the project itself had about 520 participants over 3 years. We had an intervention group and a control group. The intervention group provided access to a mental health clinic and medical clinic that had a large amount of coordination and communication between the medical provider and psychiatric provider. And they were also assigned a peer support specialist to help them navigate services and to provide some of that support and relationship building. The control group had access to the existing mental health clinic and the existing medical care clinic, which was a neighboring FQHC, but they did not have access to a peer support specialist. It looks like my slide disappeared. Okay, there it is. A little bit of information about certification. It does vary by state, but in Texas, there is some training for certification provided by Via Hope Texas Mental Health Resource for mental health peer support specialists, and the Department of State and Health Services and the Texas Certification Board of Addiction Professionals do help with substance use recovery coaches. And just to provide a brief overview of the kind of training that peers in Texas might receive, there's some information on this slide about certification through Via Hope Texas Mental Health Resource. Some requirements on becoming a peer support specialist are you need to be 18 years or older. You need to have lived experience in your mental health recovery and be willing to publicly identify as a person in mental health recovery who would speak about their experiences. The training is 40 hours over 5 days, and it covers recovery process, the role of a peer in recovery, ethics, effective listening, whole health. They have a code of ethics for peer support specialists in the state of Texas, and to maintain certification, people need to complete 20 CEUs in 24 months, 3 of which must include ethics and 3 of which must include cultural competency. Other additional trainings that Center for Healthcare Services included once people were hired were home visiting safety, trauma-informed care, recovery-oriented systems of care, and crisis intervention training. Via Hope Texas Mental Health Resource also has an eCPR training that provides crisis intervention information for peer support specialists. So one of the big questions that we have gotten a lot is, how do you know who to hire? How are you measuring, who would be a good peer? Because the job requirements aren't like the usual job requirements, like a degree or something like that. So certification certainly helps, but you really want to know, what is the quality of this person's lived experience? What experiences do they have to share? How good they are sharing those experiences? So we implemented the use of an attestation statement, and it was based on the billing requirements for Medicaid for our state. And so what we would do is do some phone screenings. As Jamie mentioned, it is a comparatively new position, and not everybody may be familiar with the requirements of this position. So a lot of applicants did not understand that they needed to have lived experience and be actively working in mental health recovery. So the Texas Medicaid billing requirements were to have your high school diploma or GED and to have 1 cumulative year of receiving mental health services for a disorder that is treated within the target population for Texas, which for us is major depressive disorder, bipolar, schizophrenia, schizoaffective. So we would read that requirement directly from the Texas Medicaid billing and just let people know, if you meet these requirements, say yes. If you don't, say no, and don't feel pressured to share your specific diagnosis or information that is really your private health information. We're really wanting to know more about your recovery and if we would be able to bill for services. So outside of just that general definition, what makes a really outstanding candidate for a great peer support specialist? So if they have certification through Via Hope Texas Mental Health Resource, it's a great quality for them to have. They have some understanding of ethics, they understand the code of ethics, they understand how to effectively share their story and communicate with others the reality of recovery and inspire hope in people. Also, any kind of volunteer experience serving other people working in mental health recovery. I know in San Antonio we have a local clubhouse where people may have provided some informal peer support or working in NAMI peer-to-peer or in prosumers. Also, anybody who might have work experience in customer service who has really good interpersonal skills. Also, we want to make sure people have sort of the practical skills to be able to complete job duties. So could they have enough computer proficiency to document services in our electronic medical record? Outside of those very practical sort of operational things, some of the big things we wanted to look at was, can they speak about their recovery? When we were interviewing people to become a peer support specialist, were they really illness-focused, or did they have a very strong recovery focus? Were they able to identify and share specific strategies for how they got well or how they've helped other people identify paths to wellness? Another good thing is, now that you know what's worked for you, are you open to working with other people on lots of ways to wellness, not just one way, and being really culturally competent and understanding that different people have different goals and different meaningful things that they're working towards and different ways to get there. And another thing is kind of assessing boundaries of a professional helping relationship. So because peers do have a strong element of mutuality as part of their work, they wouldn't have the same boundaries as a social worker or a nurse or a psychologist or a psychiatrist, but they would want to know a little bit about power dynamics, coercion. How do you know that what you're doing is helpful as opposed to harmful? So once you've hired some great peers and you're looking at integrating those services into your existing clinical teams, some things that we found really helpful as we learned along the way, and I was so appreciative that the amazing peers I worked with were very patient as we were kind of blazing this trail together, was accurately defining their scope of practice. This is new to many clinical teams, this position. So really laying out some specific job duties that are uniquely peer activities that could be really powerful. And these job duties should be things that are really maximizing on that peer empowerment rather than, things that the team just needed somebody to do. So peer-run groups are really powerful, helping people prepare and debrief after appointments to make sure, are you effectively communicating what you need? Are you getting what you want out of services? And if you're not, how can I help you attain that? These are your services. How can we help put you in the pilot seat? So a lot of consumers that we serve or individuals in service, they may have been in services for a very long time, and now we are moving towards recovery-oriented care, but they are very much sort of indoctrinated into, you show up, you have this medical model where you receive medication, you're prescribed a plan, and all of a sudden they're wanting, the system is wanting people who've had that experience before to suddenly say, okay, now you need to know everything you want, and bring forth all of these new skills in self-advocacy. And so I think peers are the absolute best person to be teaching self-advocacy skills and how to step in and really take an active role in their recovery. Another big part of integrating peer services is making sure other employees and staff members know about peer services and the role of a peer. So at the Center for Healthcare Services, every new employee orientation includes a presentation from one of our certified peer specialists, and it's really interactive, and it helps people understand the value of peers and the role of a peer in services. Now, outside of people just knowing about peers, we need to know how to connect people with peers and do that in a way that doesn't result in a huge influx of referrals to one peer, and it's a manageable workload to where peers can provide quality services, but that people are making those connections. So really have clear procedures for referrals. And then at the beginning, we did need a bit of technical support on inclusion of peer services in the electronic medical record. We wanted to be sure that the services that were documented were really reflecting peer work and not clinical work or clinical jargon, but how could we make sure that we were really encapsulating the powerful work that they were doing and reflect how it was helpful to people's recovery. So the career ladder is another part of integrating peer services. Because it's fairly new, we wanted to be sure that peers who were hired had a clear path to getting somewhere and building their skills and growing as a professional, as a mental health professional. And so we sort of created this peer career ladder. And a big part of this also kind of underscores and highlights the importance of mentorship, both informal and formal. Because this is a really new role for a lot of clinical teams, it can be really isolating. And so it's really important for peers to be able to have other peers to talk to meet with, to problem solve with, and to advocate for themselves within our agency and within our system. So those were sort of the, in a short, flash, some of the big things that we learned that we wanted to share. And I'll pass now to Crystal Blylar.
Thank you, Kimberly. So it's a pleasure to be here to present the results of Mathematica's evaluation of PHNY and Project Health. We followed each of these awardees over a 3-year period and watched with great interest as they developed their models, defined the roles of the peer support specialists, and ultimately succeeded in addressing challenges in incorporating peers into clinical care teams. I'm going to start with Parachute NYC. For Parachute, our evaluation employed a difference in differences design that involved comparing the intervention group to a well-matched comparison group. The analyses focused on the subgroup of Parachute participants who were enrolled in Medicaid and who used the crisis respite centers. The comparison group comprised other Medicaid beneficiaries in New York City who were hospitalized for psychiatric crises during the same time period and were individually matched to Parachute participants on numerous demographic, clinical, and baseline service utilization factors. Our analyses for Parachute focused on several core service utilization and expenditure measures that CMS had identified as common measures to be assessed across all healthcare innovation awardees when possible. The first measure we analyzed was total Medicaid expenditures per person per month. In this figure, we show the total expenditures per 6-month period for the intervention and comparison groups for 3 years before and 2 years after enrollment. As you can see from this graph, expenditures were very similar for the two groups during the 3-year baseline period, marked as B1 through B6 on the graph. In the year of enrollment, however, marked as I1, expenditures were significantly and substantially lower for those who used CRC services, that's the blue line, than for those who were hospitalized. In the second year after the crisis respite or hospital use, however, expenditures for the two groups were again similar. This next graph suggests that the differences in expenditures between the two groups is primarily due to the cost of hospitalizations. Note that although the intervention group used CRC services initially for their crises, some were also hospitalized within the first 6 months after visiting the CRC. Note further, however, that the comparison group, which went to the hospital initially rather than to the crisis respite center, experienced significantly and substantially more hospitalizations within the first year after the initial hospitalization, for an average of almost 4.5 hospitalizations within the first 6-month period. As with expenditures, the number of hospitalizations in the second year after the initial episode was again similar between groups. Overall, the crisis respite center intervention saved an average of over $1,600 per beneficiary per month in Medicaid expenditures. These savings appear to be due to reductions in hospitalizations, and not just the initial services, but also additional hospitalizations over the next year. We found no impacts on use of general hospital emergency departments. So moving on to Project Health. Project Health was somewhat unique in that they employed a randomized design, which is, of course, the gold standard for intervention research. As Kimberly described, the intervention group received integrated on-site behavioral and physical health care and support and coordination from peer specialists. Control group participants also received mental health services on-site and staff assistance with linkages and referrals to existing social services and resources. But if they needed primary care, they had to obtain those services through the neighboring federally qualified health center. And many of the CHCS staff and residents told us in qualitative interviews that they considered those services to be inadequate for addressing their physical health needs. Group members didn't have access, control group members did not have access to the peer specialists or any mechanism for coordinating care obtained from the FQHC with the services provided by CHCS. We obtained the data for our evaluation of Project Health from clinical assessments that CHCS administered at baseline enrollment and 6 and 12 months post-enrollment. These data included assessments of both physical and psychological health, including body mass index, blood pressure, psychological distress, quality of life, motivational readiness for change, and hope. Overall, we found some significant and substantial improvements in physical psychological health in both groups, including over 1/4 of both groups lost at least 5% of their body weight, over 40% of the intervention group and 30% of the control group were no longer hypertensive at follow-up. Systolic blood pressure decreased in both groups. and both groups improved on all measures of psychological health. However, none of the differences between groups were significant. But despite the lack of significant differences, we're hesitant to say that there's no added value of Project Health's peer specialists and integrated care model for several reasons. First, our sample size was small, with fewer than 200 people per group for most analyses, so we may not have had sufficient statistical power to detect some true effects. Second, we followed each individual for only 1 year or less, so it's possible that effects would increase over a longer period of time. Third, CHCS staff hypothesized and believed, according to our qualitative interviews, that the intervention did reduce hospitalizations and ED visits, but we didn't have enough participants enrolled in Medicaid or Medicare to test this with available data. And then perhaps most importantly, the success of CHCS's standard care provided to the control group may just be too good, which would make it very difficult to demonstrate further improvements. We're also hesitant to conclude no effects of the CHCS model because of what we heard through our qualitative data collection efforts. For all of the HCIA behavioral health awardees, we conducted 2 rounds of site visits, during which we interviewed administrative staff, workforce members, and other stakeholders such as advisory group members, technical assistance providers, and external service providers. In the second round of site visits, we also conducted focus groups with members of the workforce, intervention group members, and, importantly for Project Health, control group members. Our qualitative interviews uncovered a lot of information about what works and what doesn't work in helping to incorporate peers into integrated care systems. And these ideas are very consistent with what you've heard from Jamie and Kimberly. First, senior and mid-level organizational leaders must actively champion the peer support program to educate existing staff about the role and value of peer support and engage them in collaborating with new peer staff. In the early stages of HCIA, we saw that in some of the sites, professional staff were really struggling to understand the peer role and the recovery model, and peer specialists were struggling to feel accepted and supported. But with buy-in from the leadership, we saw the sites develop strategies to overcome these challenges, and by the end of the projects, teams seemed to have developed mutual respect and good working relationships. As Kimberly described, one strategy that seemed to be important across sites was to establish a supervisory structure and other emotional support resources for peer specialists. These resources provided strong support, were flexible, and were adapted to and conveyed an appreciation for the unique circumstances of peer staff, many of whom may have limited experience with professional work and may be attending to the needs of their own ongoing recovery. Such supervision and promotion of self-care were thought to be critical to reduce stress and burnout among peer staff. And finally, as the projects proceeded and peer specialists became more comfortable in their roles, they began to look for professional growth opportunities. In order to improve morale and commitment and prevent staff turnover, as peer staff may seek advancement elsewhere, organizations may need to establish a clear trajectory for an investment in professional growth and advancement for this new workforce, as Kimberly described. I want to close with what we heard from interviewees about the added value of peer specialists. Staff and program participants we interviewed valued the peer specialists for the motivational support they provided, their ability to help consumers better understand their health conditions and how to manage them, and the assistance they provided participants in obtaining, navigating, and coordinating medical and other services and supports. In contrast to the positive feelings about peer specialists helping participants to access services, Project Health control group members who did not have access to peer specialists expressed substantial frustration with the limited support they received in accessing services. Most notably, without any prompting by us, They recommended that CHCS should hire staff with shared experiences, that is, peers, believing that peers would have greater empathy with their circumstances. And indeed, the program participants we spoke to did feel that the peer specialists had a unique ability to empathize with their situation, and that this empathy led to a greater degree of genuine concern for their needs. As an example, one participant said of her peer specialist, "She makes me feel important as an individual. She makes me feel like I'm loved. She makes me feel like I'm cared about. Somebody actually worries about me and my kids. It's not just me. She worries about my family, and it means a lot." So with that, I'll turn the presentation over to our discussant, Dan O'Brien. But first, we have another polling question for you, and Vatisha will present the results of the poll at the conclusion of Dan's remarks. Dan?
Yes, thank you. Good afternoon, everyone. In order to answer the question that is the title of today's webinar, Accessing Behavioral Health Services, Can Peer Support Help?, I've been asked to comment on the material you have all just had presented here. So I guess in general, I would start with the comment by Dr. McClare in the first set of slides that some peer support studies have shown decreases in hospitalizations, 30-day readmissions, involuntary admissions, service utilization costs, and so on, that I would have to say that indeed the answer would be yes, that peer support services do help individuals with accessing behavioral health services. If indeed the hospitalizations overall and those within 30 days of the most recent hospitalizations are decreased, the cost of mental health care is decreased, and therefore there would be potential openings for other individuals who need care in these services. If individuals who are receiving peer support are better satisfied with their personal circumstances and have increased hope for recovery, empowerment, self-esteem, self-efficacy, and self-management, then indeed there will be increased access for care. But I do agree that most studies are not conclusive and have some inherent design or other study flaws. More research is needed, and as part of my work in the VA, we constantly are connecting with research teams to come up with new studies that might shed light on peer support's effectiveness across the VA. Now let me address the individual presentations that we heard about some of these interventions utilizing peer support. In terms of the peer respites in Project Parachute in New York City, I love the concept, Jamie, and I'm very impressed with the outcomes that Mathematica provided on the 4 respite programs there. A few questions that I would like to hear answered would be about how the state determined that it was the most financially successful new behavioral health service model. What were some of the initial startup costs for obtaining properties in which the respites resided? What were challenges, if any, from the neighbors, the old NIMBY issues, not in my backyard, for having folks who have stigmatized health conditions? So what were some of the challenges and how were they overcome? And were there potential risk liabilities that you all had to discuss and resolve to manage for perhaps insurance coverages in case something did occur in a residence or a respite? Mm-hmm. So that presentation really brought up perhaps more questions for me, because we don't have that kind of service in VA, although we are proud to say that we know that Steve Michio, who is one of the pioneers in that area, is a veteran, and we certainly would be interested in learning more at some point and perhaps participating. Now, the best practices in hiring and integrating a peer workforce section by Kim. Kim's presentation contained key elements to address to ensure that peer support services do positively impact access to behavioral health services, particularly having good job descriptions, focusing on appropriate lived experiences and the individual's ability to articulate them, integrating peer support services into primary care, whole health, and preventative care services, having a career ladder that goes from an apprentice to a supervisory level, which, by the way, the VA will soon have accomplished a full career pathway that contains all of those positions soon. And then in the evaluation of these programs by Mathematica, Crystal talked about the data on expenditures and hospitalizations for those using the Parachutes program's respite care during the study. The first year was impressive that there was such a degree of differentiation between costs and number of hospitalizations. But I do have a question. You know, I wonder what it was that changed behavior so significantly that they didn't need hospitalization or they didn't choose hospitalization during that initial exposure to the respite. What happened after that first year when the baseline recidivism and costs returned? Was there perhaps peer staff turnover in the respites? Did the availability of the respites become less obvious to those in the study and they stopped using it? You know, just theoretically, you know, hypothesizing about what those questions might be to answer why we had that change. So perhaps more studies would support the use of peer respites. As I said, I know that I'm interested, but would need to have community support and full participation by community members and collaborators to have the VA go in this direction in the future. But we certainly would be interested. On the Project Health, the comparison of those two, what I believe were homeless groups. The intervention group received integrated behavioral health and the physical health care along with support and service coordination from peer specialists. And the control group received on-site mental health services and staff assistance with linkages, referrals, and primary care from local federally qualified health centers, which is kind of business as usual. Interestingly, the comparison of these two groups didn't reveal any advantage to having peer specialists be part of their services in any significant way, which, again, this is disappointing, but it's only one small study and points to the need for more studies with larger sample sizes. And as Crystal pointed out, there were still some within the group that received the peer support services advantages. There are also other studies outside of this, of course, in the private sector, a group known as Peers for Progress that do link beneficial healthcare outcomes to accompanying them with peer support. The lessons learned from the qualitative analysis, in my experience, having had the honor of leading the peer support implementation in VA for the past 10 years, where we went from a workforce of only 187 peers spread out over 170 facilities to having 1,100 now. And I can affirm slide 45 that you all saw a few minutes ago, which said that senior and mid-level organizational leaders must actively champion the peer support program so that there's education for existing staff about the role and value of peer support and to engage them in collaborating with the new peer staff. That supervision and promotion of self-care are critical to reduce stress and to burnout.